Good evening, everyone. Welcome to the second installment of our Sigma Virtual Hour, where we are discussing the topic of diabetes. Last week was our first discussion and our first workshop, which gave us an introduction about diabetes, what diabetes was, what the different type of diabetes were all about. And tonight, we are back again with a second infusion of it, and we are just blessed to have with us tonight Miss Amy McMillan from EVMS, as well as Dr. David Leave from EVMS as well. And so at this time, what I want to do is just turn things over to Miss McMillan to just reintroduce herself to us and to get things off with our presentation tonight. Thank you.
Awesome. Thank you so much. Hey, everybody. I'm so happy to be back. Last week was such a great time. So we are back today. We are getting a talk from Dr. Lieb. And before he goes into his presentation, I wanted to review these awesome studies we have at the center. So we have this study that is a lifestyle-based intervention study that is looking for people who identify as African American, ages 25 to 55, and who are at higher risk for type 2 diabetes and or have pre-diabetes. And it is compensation to participate. You get free wellness checks. There's free cooking demos and lessons. And it's to see if this personal nutrition program can help the population and participants eat healthier without giving up your favorite flavors and your culture's cuisines and cooking. So again, we are spreading that out. Please share with your friends, your family. We're looking for African American males. So, share it with your brother, your uncle, your dad, whoever you think would be interested. We have another study here on the right side of the screen, and that is called Pathfinder 2. It is an early cancer detection test coming in, and it can look up to 50 biomarkers of cancer in just a blood draw. And it also can look at the location. So if that's something you'd be interested in coming in for, please contact Jordan right there in that contact. And I will also have a QR code at the end of this. And then Dr. Lieb, if you can switch that next slide for me. Awesome. So I wanted to review a few more studies like we did last week. We have another study going on called Achieve 4. It's looking at an investigational medicine for people with type 2 diabetes and who might be at higher risk for heart disease or stroke. So let's say you were kind of interested in that previous study I just mentioned, the lifestyle one, but if you already have diabetes, you can't participate. So this is another option for you. The one in the middle is for people who have uncontrolled high blood pressure. That's another investigational medication study. And then the last one there on the right of your screen is looking at painful diabetic neuropathy and looking at this thing called Nevro HFX as a treatment for this neuropathy. So if any of these apply to you, we can go to the next slide and you can actually scan the QR code on the right of your screen. It says a research interest form, or you can type in that link below. And with that, you can notate your interest in any of the studies that we have going on at the center. And then to the left, we have our website to kind of go over those studies, just a little more detail for you all if you want to take a look. So again, check out our website. A lot of community engagement going on, and we would love for you to be a part of it. So thank you all for your time today, and I'm so happy to be back. Without further ado, I will go ahead and pass the mic on to Dr. David Lieb, who's an endocrinologist at EVMS. We are so happy to welcome him today. And on to you, Dr. Lieb. Thank you.
Thank you so much, Abby. And thank you, Kivon, and everybody here for inviting us to talk about something that's near and dear to all of our hearts, diabetes. I have type 1 diabetes. I was diagnosed when I was 12. So any opportunity to get the word out and help other people that have this disease, I definitely want to do that. So thank you to all the members of Phi Beta Sigma and everybody that's here for participating. So some of what I talk about tonight will be a little bit of a review, I think, from what Abby had talked about previously during the first workshop. And I may go through some of that a little bit more quickly with respect to the diagnosis and the sort of background of what diabetes is. I really want to get to the medications and the monitoring and allow folks to ask questions. So hopefully this will be interactive as questions come up. I'll do my best to answer them. Hopefully we won't hear my children in the background. I can't guarantee that. My middle son, Elliot, is 14 and for some reason enjoys playing ragtime piano. A little strange. I'm not really sure where that's going to lead him, but you may hear it in the background. If it starts, I may have to step up for a second and tell him to stop. I'm a professor of medicine at EVMS. I've been here in Norfolk since 2009. Grew up in Richmond, where my parents still live, not too far away. I'm the vice chair for education for the Department of Medicine, and I'm on the board of directors for the American Diabetes Association locally here in Hampton Roads. So I think y'all talked about the sort of the basics of diabetes last time, but just as a refresher, the main issue with diabetes is that people can't utilize the sugar that they eat that is normally energy for every cell in the body. And you get sugar or glucose from the things that you eat, but also from storage of glucose in your body. So I like to tell people the liver is like a big refrigerator for glucose. The kidney stores glucose, your muscle stores glucose, so that when you need that energy, when you're asleep and you're fasting, not hopefully eating anything overnight, your liver releases glucose so that your brain is getting fed. When people have diabetes, they can't utilize that glucose properly because of problems with insulin. And there are all kinds of different conditions that can lead to insulin problems, but the most common are type 1 and type 2 diabetes that I'll mention briefly. So when you've got diabetes, it's almost like you're starving. And that's why people feel so poorly before they're diagnosed and treated. Type 1 diabetes, which is what I have, tends to be diagnosed in younger individuals. It's diagnosed with a set of antibody tests because it's an immune disease. But I see people who are in their 60s that are diagnosed with type 1 diabetes. They used to say that it was only kids, that it was only thin individuals. That's not true either. People with type 1 diabetes gain weight just like everybody else. I can attest to that personally. Type 2 diabetes is probably 90% or more of people with diabetes, and it tends to occur at an older age. There's a much stronger family history connection with type 2 diabetes, but unfortunately, we're seeing children that are being diagnosed with type 2, especially with obesity affecting children. So in both conditions, there's a problem with insulin, which is the hormone that helps the body to manage blood sugar. In type 1, you just don't make enough, so people have to take it. But in type 2 diabetes, you don't make enough and it doesn't work very well. So about 30% of people with type 2 diabetes end up needing insulin to help control their blood sugars, but oftentimes they can take other medications that we'll talk about that help to improve the function of the insulin itself. So with respect to diagnosing diabetes, I think y'all may have touched on this earlier. We use a few different markers. There's the test called the hemoglobin A1C. That is an average measure of how much glucose there has been in your blood over the last 2 to 3 months. I'll talk about that a little bit more in a minute. We can measure fasting plasma glucose. So you come in, maybe you haven't eaten anything for the last 6 to 8 hours, and you have a glucose measured. There's also something called an oral glucose tolerance test that's often done in pregnancy for gestational diabetes, less often for other types of diabetes. So we really focus on the 2 columns, the A1C and the fasting glucose. There are cutoffs based on either your fasting blood sugar or that hemoglobin A1C, which is measured in percent. And the numbers come from studies that show that once you have an average fasting blood sugar that's greater than 126 or 125 consistently, or that equates to about this A1C of 6.5%, that's when people start developing complications of having too much sugar in their blood long term, and we'll go over some of those together. There's a condition called prediabetes, which is it's basically just on a continuum. So people that have prediabetes are at risk for developing diabetes. So it's worthwhile to know if you have that condition as well. It's important to mention that diabetes, specifically type 2 diabetes, is 60% more common than it is in non-Hispanic white men. We'll talk a little bit about why that is. Just a brief comment on prediabetes. So it's a lot of people. About 60% of people will go on to develop frank diabetes without some intervention. The intervention could be helping people to lose weight with diet and physical activity. It might be medications. The common medicine that many of y'all have probably heard about is metformin. It's been around since, I think, 1990. But it's a lot of folks. It's 1 out of every 3 people in the United States. And most people with prediabetes and a significant number of people with type 2 diabetes don't know that they have it. So if you don't know you have it, there's not much you can do about it. Just a quick comment about the hemoglobin A1C test. So you can see in this figure that if there's more glucose in your blood because you've got diabetes that's not well controlled or hasn't been diagnosed, the red blood cells the hemoglobin in the red blood cells get covered with glucose. Versus a red blood cell that doesn't have as much glucose in its environment. You can see there are less of these little yellow glucose dots on it. So A1C is a great test, but red blood cells have issues. And if you've got a thalassemia or an anemia for some reason, then this test is not going to be very accurate. And there are also differences that have been identified in blacks versus whites with respect to A1C. And African Americans tend to have a slightly higher A1C at the same blood glucose levels. So people can be falsely diagnosed with having diabetes or prediabetes when really they don't necessarily have it. There are probably some genetic reasons for that with respect to red blood cells, increased risk of things like thalassemias in the Black community too, are things that you have to watch out for. So anytime you're diagnosed with diabetes or with prediabetes at a screening or somewhere, you should probably have those tests done again to make sure that it's the correct diagnosis. And y'all may have discussed this before regarding who should be screened, and there are a number of different screening tests that are used in questionnaires like this one from the American Diabetes Association. But these sorts of scores don't take into account other factors, including race, and we know that African Americans are more likely to develop diabetes, or factors that are important in your community. What's the prevalence of diabetes in your community, geographically, where you live, the people that you live near, and local factors like food access and housing and employment all affect one's risk for diabetes. And future diabetes risk scores are going to take these sorts of things into account. So why is diabetes more common in African Americans? Like most things, it's multifactorial, and that includes probably some biology, but also socioeconomic and lifestyle factors, the social determinants of health, limited access to healthy foods, poverty, lack of safe physical activity opportunities, inadequate housing, inadequate employment, educational disparities. All of these factors are associated with increased risk of developing diabetes. And due to systemic and systematic racist policies, many African Americans are in communities where, we know have higher prevalence of poverty, inadequate housing, problems with food access, educational disparities, all of these things. So these are factors that, in addition to managing diabetes with medications, we need to think about assessing the community, caring for the community, changing policies in government, and all those kinds of things to help reduce diabetes. Some of the complications of diabetes, I think, those of you that have diabetes or that have family members or friends with diabetes know that it really affects all parts of your body. And it's because the high blood sugars can affect big blood vessels like your heart and the vessels that go to your brain. It can affect the small blood vessels in your feet and in your gut and in your kidneys and your eyes. So there's certainly an increased risk for cardiovascular disease, including heart attack and stroke. There's increased risk for neuropathy or numbness in the feet. There's increased risk for ulcerations in the feet because of vascular flow and the numbness. People don't know that they've maybe injured their foot until they have an infection that started. Dental care is important. People with diabetes are at increased risk for infections in the mouth. In sexual health, erectile dysfunction is incredibly common. It's especially common in people with diabetes due to the vascular disease that we develop. And I also wanted to mention mental health. It's not easy living with a chronic illness like diabetes. There's this concept of diabetes distress that we're studying in EVMS. One of my friends and fellow faculty, Dr. Chinelo Kibo, is very interested in diabetes distress. It's just a lot to do. The monitoring, the doctor's visits, all the medications, and so it often leads to distress and even to depression and anxiety. So it's a disease that affects every part of you, but fortunately, there are things that you can do. If I'm going too fast, let me know, because sometimes I talk too fast because I want to make sure that I get the information out. With respect to diabetes complications in the African American community, we know that compared to the white population, African Americans have higher rates of eye disease, higher rates of kidney disease and heart disease, also higher rates of high blood pressure. Again, why is that? A lot of it involves the social determinants of health that I mentioned, which importantly includes access to healthcare. And I would say that that includes access to trustworthy healthcare. In this country, we have a long history of Blacks being taken advantage of by the medical community, from experimentation that was done in the 1800s. The father of modern obstetrics, this guy J. Marion Sims, was lauded for all that he had done for obstetrics and gynecology, but was involved in doing experimentation in enslaved women. The Tuskegee experiments from the 1930s that led all the way to the 1970s, when the US government, the Public Health Service and Centers for Disease Control, were allowing people to live with syphilis without treating it. To more recent things in the 50s and 60s, I think people know the story of Henrietta Lacks, whose cells were taken from her and used by researchers around the world for research without her or her family knowing. I'm constantly hearing news stories. One thing that I hadn't learned about growing up in Richmond, I didn't know this. Bruce Tucker was an African-American man who had his heart was transplanted into a white man in 1968 in Virginia Commonwealth. Again, without informed consent, without knowing that that's what was going to happen to his heart. So I think it's important that physicians and healthcare providers know this history. And I think that there's a need for more bias training among physicians and clinicians. And also we need more Black clinicians. One of the things that I'm involved in with some of the endocrine groups, national endocrine groups I'm part of, are helping to get the word out about endocrinology to high school students and medical students and college students that are trying to get people interested in endocrinology care. So that's small soapbox stuff. I'm going to get back to the medications too, but I think all this is very important. With respect to management of diabetes, lifestyle changes and preventive care are key. So if you've been diagnosed with diabetes or prediabetes, I would hope that your doctor or nurse practitioner or physician associate has recommended that you see a dietitian, helped you with getting some sort of regular physical activity, and getting you connected with education. There are trained diabetes educators who are wonderful. It's important that you have regular visits with your doctor and have screenings for complications, including eye disease, neuropathy in your feet, kidney disease, heart disease, all of these things. And again, addressing community needs is also part of managing diabetes. But not everybody can reach their diabetes management goals with lifestyle therapy alone. everybody that has type 1 needs insulin because our bodies just don't make it. Sometimes if you're diagnosed with type 1 diabetes as an adult, you may go for 6 months or so and not need insulin, but typically after that, people require insulin. And about 30% of people with type 2 diabetes benefit from insulin. And it's all about treating with whatever's necessary, whether it's lifestyle therapy or medications, to help folks get to whatever their individualized glucose control goals are. So if you're someone who's young and pretty healthy without a lot of complications, your A1C goal may be 6.5 or 7%, which is pretty close to the lower end of the diabetes diagnosis range. If you're 85 and you've had diabetes for 30 years and you have heart disease, your A1C goal is not the same. It's going to be higher. We allow for higher blood sugars because the risk of giving so much medicine to get the blood sugar down is not worthwhile. The risk of low blood sugars is a much bigger issue. In the past, I would say managing diabetes was mostly about blood sugars, but now we have medicines that I'll mention that can help to reduce your risk for heart disease, especially if you have a history of heart disease. We have medicines that can help to protect the kidneys in people with kidney disease, and medicines that reduce your risk for stroke. So it's more than just the blood sugar. We're looking sort of at the whole person. So we have medicines that lower sugar, that can help people with weight loss, that improve kidney disease, that prevent hospitalizations for heart failure, that reduce the risk of having a stroke, and that reduce death related to heart disease. But these medicines all have side effects and potential long-term risks, varying costs. As y'all know, some of these are incredibly expensive and not everybody has access to them. And there's issues with availability, especially for some of the newer medicines like Ozempic. So before talking about some of the specific medicines, I wanted to talk about one of the more common concerns that people have, which is low blood sugar. And I can pause there too, if there's some questions or if people wanted to ask anything before I move on.
No, this is all interesting. Please continue.
I think I'm a little more than halfway through the slide, so we'll have lots of time to talk. But
Absolutely.
So one of the things I wanted to talk about was hypoglycemia. So hypoglycemia is the opposite of diabetes. It's having too little glucose in your blood. It's typically related to the medications you're taking for your diabetes. Some of them are associated with low blood sugars, but not all of them are. Physical activity, the more active you are, the more sugar you're burning. And diet, if you're not eating as much, but you're still taking your medicines, all of those things can cause a low sugar, typically something less than 70. And it's really an emergency. If hypoglycemia is left untreated, you may pass out, you may have a seizure because your brain doesn't have enough energy to do what it needs to do. And so a low sugar needs to be treated right away. And it's scary for a lot of people. It's a scary side effect when you've experienced a low blood sugar. People get really anxious and have trouble keeping their sugars well controlled because they're worried that it's going to happen again. Some of the common symptoms of low blood sugars are shaking or sweating. It's all kind of like your body starts making more adrenaline because it's trying to raise the blood sugar. People get incredibly hungry, have a fast heart rate. Sometimes people get a tingling around your mouth. And it can progress all the way to somebody just being so confused that they're not able to take care of themselves. When that happens, we have some things that you can treat low blood sugars with. For a low blood sugar that you know about, where you don't feel great, you check your blood sugar and it's 50. Everybody's got glucose tablets. I've got glucose tablets next to me, but I realize if I put them up in front of the screen, they'll probably just be blurry. But I try to carry these around with me all the time. You eat a few of them and it raises your sugar back up after about 15 minutes. There's also a medicine, a hormone called glucagon that's available as an injection or available through a nasal spray, so that if you live with somebody with diabetes, they should have, and especially if they're on insulin or a medicine that increases their risk for hypoglycemia, you should have all these things available for that person.
Question for you, Dr. Lee.
Yep.
So this is a question from our online audience. We have a member that wants to know about the reversibility
Yep.
of diabetes. Can you talk about that between type 1 and type 2? And the next question is going to also be regarding these medications. Are any of these over the counter?
Oh, these are great questions. Okay. Um, for the medicines that I'm going to show in a minute, generally speaking, they are not over the counter. You need to have a prescription. Some medications are free because they've been around for so long. I think like Harris Teeter maybe has a deal with companies so that they can give people metformin, which is one of the most common diabetes medicines, away basically for free. But you still have to have a prescription. There are types of insulin that you can buy over the counter without a prescription. And it's because insulin is considered life-saving. And so if somebody with type 1 diabetes, for instance, needed insulin, without it, they would end up in the emergency room pretty quickly. And so there are insulins that are available over the counter. And I've got a slide that talks about some supplements that are available over the counter too, but they don't have as much data behind them. The reversibility question is great. So oftentimes when people come in and they're first diagnosed, the first thing we do is hopefully get a good dietary history. And if people are drinking a lot of juice or sugary sodas or, sweet tea or something that's got a lot of sugar in it, the reason that people are drinking those things so much is because their blood sugars are high. It's making them thirsty because they're urinating all the time. And then they're drinking things that are sort of adding fuel to the fire. And if you can stop that and start drinking water and decrease starchy foods that are in your diet that raise the blood sugar, sometimes people have some pretty amazing responses to just lifestyle change. If you have type 1 diabetes, unfortunately, that's not going to go away because that's this autoimmune condition where you have destruction of the cells that make insulin, and there's just nothing that can replace that right now. A lot of research in that area, but there isn't something for people that develop type 1. For type 2 diabetes, there are many people that can control their blood sugars with diet. They reach those A1C goals, they feel well, their risk for developing kidney and eye disease is reduced significantly. And for some people, if you start a medicine, it doesn't necessarily mean that you're going to stay on that medicine forever either. One of the things that I often hear is, if I start insulin, am I going to be on insulin for the rest of my life? Sometimes, if it helps, and it's necessary, if someone's had diabetes a long time, sometimes their body just can't make enough insulin, even if they have type 2, but not necessarily. So I try to have those conversations with people. I will say the diabetes is never fully gone because you've got whatever the genetic predisposition is in your body to develop higher blood sugars than somebody else who's maybe in the same environment. And so a good example of that is if somebody has bariatric surgery and they lose a lot of weight, oftentimes if they're on insulin, maybe they even come off it, their blood sugars are much better. But as people start regaining the weight or changing their diet, oftentimes the blood sugars start to come back up again. So I'm always hesitant to say that it's completely reversible or cured, but there's certainly things that you can do to come off medicines or require less medication therapy for sure.
Wow, that's great answers. So I heard you say that type 1 diabetes is an autoimmune disease. My next question is, if it is an autoimmune, then can someone see an immune specialist, or do they have to go through endocrinology?
That's a good question. like many endocrine diseases, like hypothyroidism, thyroid disease is really common, adrenal disease, type 1 diabetes. We don't have good therapies for stopping the immune process that's causing the destruction of the endocrine gland that's making the hormone you're worried about. And so there isn't anything that an immune specialist would be able to do necessarily. And mostly you're kind of stuck seeing the endocrinologist or your primary care doctor and being treated with insulin, for type 1 specifically. There was a new drug that was approved by the Food and Drug Administration last year that is one of the first drugs that's been shown to address the immune system, to decrease the antibody production that's involved in destroying these cells, the cells that make insulin, the beta cells. And it's currently approved for people that have kind of a precursor to type 1 diabetes. So if someone's at high risk, you can measure some antibodies in their blood. So like, my older sister, for instance, just genetically is at some increased risk. My kids, my 3 boys are at some increased risk. If they had positive antibodies, we could enroll them in a program where they would have their blood sugar checked every so often. And if it was not in the diabetes range, but higher than it should be, they would potentially be candidates for this medication. So it's really exciting. There's more data coming out in people that already have type 1 diabetes, but have been recently diagnosed and using this drug. It's not perfect, but it does appear to prolong the amount of time before you end up needing insulin and sort of having full-blown type 1.
Wow, I got one more question for you.
Sure.
Before we go back into our presentation. And this has something to do with lifestyle and weight management. Every now and then, if you follow some of the more famous and more exposed people who work out, you kind of see that they may have some diabetes care attached to them, and the fact that they may have one of the digital glucometers. So the question is, how does working out impact the blood sugar? Because if you were to interview some of those people who work out, they may tell you that they wasn't always that way. They may have that on because all of a sudden their doctor wants to monitor their blood sugar. So what's the impact of working out?
Yeah. So exercise can have different effects on blood sugar. Certainly chronically, as you're gaining more muscle and losing fat or adipose tissue, muscle loves to use glucose. So the more muscle you have, the more glucose is being taken up by those muscles and being turned into energy and keeping the sugar out of your blood where it shouldn't be for long periods of time. When people are on medicines that lower their blood sugar, especially insulin, but some other medicines too, when you exercise, the amount of insulin you've taken for the day may already be there in your body. And when you start exercising, you start burning some of the glucose that's in your blood because the muscles start taking it up. And sometimes, because of the insulin that's there too, and maybe other medicines that are causing low sugars, your body it can't make enough glucose to make up for what's coming out from the exercise. And so that's when someone's at risk for a low blood sugar. And so people with diabetes, especially that take insulin, have to make adjustments in their diet and their insulin doses around the time of physical activity. Sometimes blood sugar can spike up very, very quickly with intense exercise. So, when they look at people that have type 1 diabetes that are like, Olympic athletes that are sprinters or people that are sort of race swimmers, they'll find that their blood sugar may spike really high initially because as they're exercising and their adrenaline pumps into their body, the adrenaline stimulates the liver to release a lot of glucose that's been stored up. Because the body doesn't know that you're not running away from something frightening. it thinks your muscles need extra glucose. So occasionally, if somebody's blood sugars are high and they're wanting to exercise, we may recommend that they wait till their sugars come down into a better range before they start exercising.
Thank you, thank you. And we've got a question from our audience, and they want to know about fatty liver.
Oh,
Is there a relationship between diabetes and fatty liver disease?
yes. I'm so glad somebody asked that. And I'm embarrassed that I didn't mention the liver because I think it's got to be part of all diabetes talks now. Um, so so in diabetes, and specifically in people that are obese or overweight, um, the extra glucose and the fat that you're getting in your diet, sometimes the body just can't store it anywhere. And so you end up getting fatty deposits in other parts of the body where it doesn't belong. And one of them is the liver. And when fat is building up in the liver, it increases inflammation and makes the liver have trouble using insulin properly. So when people talk about having insulin resistance, uh, that's what happens in the liver when you've got fatty liver. You develop this resistance to your own insulin, and as a result, the liver is releasing glucose. It doesn't know that maybe you've got enough glucose, you're doing fine. It'll keep releasing glucose because it doesn't hear the signal from insulin. So fatty liver and obesity and diabetes are all really tightly related to one another. And the best treatment for fatty liver is weight loss, which easier said than done. There are some medications that are useful in treating fatty liver, and there's some newer medicines that are coming down the road because fatty liver or metabolic liver disease is so common.
Awesome. Thank you so much. Thank you so much. Please continue with the presentation.
Okay, thanks. And I like doing questions and talking about stuff like this probably more than even just presenting the slides. So if people
I
have
got you.
questions, please keep asking them. Um,
Absolutely.
so when I was in medical school and residency, which is not that long ago, I finished my endocrine training in 2009. Um, there weren't that many medicines for treating diabetes. There was metformin, which has been around since the 90s. There was a class of drugs called the sulfonylureas. They all begin with G: glipizide, glimepiride. These drugs have been around for probably since the 40s and 50s. And there was a relatively new drug called pioglitazone or Actos. All of these drugs are still available. They're all cheap, which is important. Metformin and pioglitazone are pills that may help to protect the heart. They've got some data that show that they're cardioprotective. And metformin and pioglitazone are not associated with hypoglycemia, which again is that thing that a lot of people worry about. The sulfonylureas are also pills, but they cause the body to release insulin whether you're eating or not. And so if you take these medicines and you don't eat anything, there's a chance that you could have a low blood sugar. So we tend to avoid them in people that have, that are older, that are at high risk for complications if they have a low blood sugar, that can't, get help, can't eat glucose easily on their own, that need help. Or people that have kidney disease, where sometimes the risk for hypoglycemia is higher. But these are affordable medicines. And unfortunately, almost everything else that I'm going to talk about is generally not affordable. So metformin gets a really bad rap. I know this because my dad will send me something from Facebook every once in a while that he reads. Metformin causes dementia. Metformin causes kidney disease. Metformin doesn't do any of those things. It is actually a drug that can prevent those problems from happening in people with diabetes. But if you're pretty sick and have severe kidney problems or severe heart disease, metformin is not a great medicine in those people because of side effects and interactions that it can have. Its biggest side effect is gastrointestinal stuff. I'm sure there are people that are listening that have taken metformin and had upset stomach because of it. So sometimes that's a limiting thing. Pioglitazone or Actos can cause fluid retention and weight gain. And the last thing that somebody with diabetes wants to hear is that you're going to start them on a drug that may cause them to gain weight. But sometimes it's a really great drug for the right person. And other medicines that we use, like insulin, are also associated with weight gain. So sometimes I'm trying to convince people in the room that, I'm telling you, you're going to gain weight, but it's going to help to lower your blood sugars. And it's a lot cheaper and easier to take a pill than it is to start insulin sometimes. So those are kind of the older medicines. Newer medicines that have gotten a lot of attention. So there's a class of medicines called the dipeptidopeptidase 4 inhibitors. The most common is probably Januvia. There's another drug called Tradjenta. These medicines have been around since probably 2006. They're pills. They lower blood sugar. They don't cause hypoglycemia because they only work when you're eating. There has to be food in your system to stimulate these drugs to work. They're not terribly potent, and they don't have any known cardiovascular benefits. They're just blood sugar lowering drugs. And they're still branded. So they're still more expensive than they should be, even though they've been around for, 15 years or more, which is gross, but just how things are. So we still use that class of medicines, but with the two classes of drugs below that, the DPP-4 inhibitors have not gotten as much attention. So the glucagon-like peptide 1 receptor agonists are Byetta was the first, Victoza, Trulicity, Ozempic. The latest and greatest is Mounjaro. So this is a class of medicines that stimulates a receptor in the pancreas that releases insulin when you're eating. So they don't cause hypoglycemia. They're actually kind of a more potent version of that DPP-4 inhibitor that I mentioned. They slow gastric emptying so that when you're eating, you feel full earlier. And that's why their biggest side effect is nausea. And it's no joke. Sometimes people are not able to continue the medicine. You have to really talk with folks about eating smaller portions, not eating anything that's too spicy. We start at very low doses and ramp the dose up once per month very cautiously. And they affect receptors in the brain that affects appetite. So one of the great things about this class of medicines is that they cause significant weight loss. And we have not had a diabetes medicine associated with significant weight loss really quite like this class of medicines. They're so effective at weight loss that the companies have rebranded them just for managing obesity. So Ozempic is also available as a drug called Wegovy. Mounjaro is available as a drug called Zepbound. And so if I see someone in clinic who needs to lose weight and improve their blood sugars, this might be a good class of drugs for them if they can afford them. They're
Question
mostly
for you.
Oh, yeah.
So as you're talking about these drugs and how they relate to weight loss, I take it that there is an observation that happens over time. So the question from the audience is going back to metformin. Is there a time in which someone should cycle off of metformin? Because our audience member who's asking the question is making the point that he knows people that seem to have been on metformin for years. So is there go ahead.
Yeah. So typically metformin continues to be effective long term. Of the older medicines for treating diabetes, it seems to have the longest potency as far as, other drugs like the sulfonylurea start to not work as well after a period of time. But if somebody develops kidney disease or if somebody develops heart failure, which are common complications of diabetes. In that circumstance, we will sometimes cut the metformin in half or stop it, because it can become dangerous because of metabolites of metformin that build up. I see people that have been on metformin for a long time and have significant diarrhea, and they say, oh, I've been on this drug for so long, it can't be that. And we'll stop it for a period of time, and their diarrhea gets better. So that's a reason to stop metformin as well. That said, most people tolerate it pretty well and stay on it long term. But if someone has to stop it, you often have to replace it with something.
That makes perfect sense. So as we talk about these medications, we do have some audience members that prefer the homeopathic route. So when it comes to uh, the homeopathic route versus the conventional medicine route, what's your take on that? Is there any herb, any supplement, or anything that they could take as a substitution for conventional medicine?
The key word I think there is substitution. So the biggest issue with supplements is that there's just not as much data showing that they're effective compared with the medications. Now, the people that make Ozempic, have billions of dollars to spend on studies, and then people are spending, thousands of dollars to get their Ozempic. So it's a cycle, and I appreciate that. And they have the money to do the big studies to get the Food and Drug Administration, approval. You don't see big studies like that for something like cinnamon or chromium, because no one's going to pay for those studies to get done. So part of the problem is there haven't been rigorous randomized controlled trials looking at a lot of these things. And so it's hard to recommend them without a lot of data to support them when we have positive data for other medicines. That said, I don't think I've ever taken a bitter melon supplement, and I'm not a big fan of tea, but cinnamon, chromium, alpha lipoic acid, resveratrol, magnesium, probably tried one of these things at some point over my life after talking to a patient who came in and said, oh, I've been taking chromium for the last 6 months. I've lost 20 pounds. My blood sugars are better. And I'm like, I'm going to stop at, Walgreens on the way home and buy a bottle of chromium, knowing that the data is really not there to support its use. So I always tell people, is it safe? Is there some data that it's safe? Will it interact with other medicines that you take? And there's a lot of information available online from places like the NIH has an Office of Dietary Supplements where you can look these things up and kind of see what side effects they may have, whether they interact with other drugs you're taking. Is it expensive? Because if it's really expensive, it's probably not worth it. If it's something that you can get in your diet, like magnesium, by eating more nuts, do that instead if you can. But something that's what I used to always tell people in clinic, but I would add, are you taking it in place of other medications that really have better outcome data? And I think that's important to think about. I have conversations with patients all the time about a lot of these different things. And I think they're fine. And I think there's some data that for some people they're beneficial, but you just have to make sure that you're not so reliant on supplements, for instance, that it's at the expense of having good glycemic control and reducing your heart disease risk and that kind of thing.
So thank you so much, by the way. So it seems that there is a lot of effort that is put into bringing blood sugar down. The question is, what happens to a person when they don't bring their blood sugar down? And the follow-up question to that is, how do most people find out that they are diabetics?
Oh, that's a good question. So if your blood sugar is high over time, in the short term, people feel more tired. They have no energy, which kind of makes sense because your body's not really eating the way it's supposed to. You're eating, but it's not getting into your muscles. The fuel, the sugar's not there. If your blood sugar gets to a certain point, usually around 200 milligrams per deciliter, which is about twice normal, your kidneys just can't deal with all that sugar. Normally, your kidneys are trying to reabsorb every nutrient that passes through them and only get rid of waste in the urine. But once your sugar is above 200, you start urinating some of the glucose out too. And because of that, you urinate more and then you get really thirsty because you get dehydrated. So people feel terrible. They're going to the bathroom all the time. They're really thirsty. Sometimes it increases hunger and people feel like eating more, which can also make the situation worse. And when they're eventually diagnosed and treated, they often don't know how bad they felt because sometimes it's gradual. It could be a gradual onset. Oh, I've probably had diabetes for months. Sometimes it's very rapid onset and people get real sick and throw up and end up in the hospital. But that's probably not the majority of people. Long term, the blood sugar can affect your blood vessels. It can form these complexes with proteins that damage blood vessels. And when you damage blood vessels, the kidney doesn't get enough blood flow, and that's when people start developing kidney disease or end-stage kidney disease, needing dialysis long term. The little blood vessels in the eyes start getting these molecules built up that affect their structure, and that's when you start having bleeding in your eye, and those are the sorts of things that eventually lead to blindness. And the same sorts of things happen with the blood vessels around the nerves, and also the big blood vessels, so your heart and your brain. So that's more long term. And we have better drugs and better ways to monitor blood sugar and address blood sugar than we had when I was diagnosed in 1989. It's so much better now than it used to be. So the key is diagnosing people earlier and then doing something about it and helping them to get access to the medications and treatments they need. The diagnosis question is great because there's always statistics that say there's a certain number of people that don't know they have diabetes, or I showed like most people don't know they have prediabetes. So the key thing is seeing a doctor. So that's important. So making sure, even if you're a pretty healthy person otherwise, making sure that you're seeing somebody who's watching your health, because if you have a strong family history, if you're obese, if you have symptoms of diabetes, somebody should think, oh, this person needs to be screened, or come to a community screening and be screened for diabetes. Women come to diabetes screenings. Men often do not come to that. We don't like to go to the doctor, and we don't like to go to healthcare screenings because I think a lot of times we'd rather just keep doing what we're doing, and if something bad happens, we'll deal with it when it happens. And that's just not a great way to address your health care. But it's it's how I think our nature.
Right. As we come to the top of the hour, this question right here is going back to some of the causation, if you will, of being at risk. In terms of low socioeconomic issues, food deserts, just any type of disparage that someone would have in their environment. I see those things as stressors.
Yep.
And so the question is, can stress induce any form of diabetes, in particular autoimmune, and how that may even correlate with the HPA axis?
Yeah. Oh, it's a good question. So with respect to type 1 diabetes, I know that there are other autoimmune diseases that may manifest when somebody's under a lot of stress. If someone's having a big surgery, for instance, like a big body stress, having a baby, things like that are sometimes associated with recurrence of immune diseases or the development of autoimmune diseases. There's some medications that are used to treat cancers, for instance, that affect the immune system in a good way for the cancer treatment, but are associated with the development of autoimmune diseases. I'm not as familiar with the data for type 1 diabetes and the association of stress with type 1, but I would imagine that there's some information there. When the body's under stress, you're making more cortisol from the adrenals, like you mentioned, and cortisol induces insulin resistance. It affects the ability of the body to use insulin properly. So there's a condition called Cushing's syndrome or Cushing's disease where people make too much cortisol naturally in their body, and those people are at very high risk for developing diabetes. Whether chronic stress of the chronic stress of living is associated with increasing that risk because of cortisol levels in the blood, maybe is less clear, but it's definitely clear that people who live in poverty, have poor access to food, experience racism. There have been some really interesting studies looking at a term, I can't remember the name of the research scientist that coined it, but it's called weathering, where, if they do surveys, there have been in African-American women where they ask questions, how often do you experience episodes of what you would consider racism, on a daily basis, on a weekly basis, on a monthly basis, or ever? And there are associations between those quantitative scores that people report and their risk for developing diabetes. And there's a lot of interest right now looking at the effects of racism specifically in different communities on the development of a number of chronic diseases. So what the pathophysiologic mechanism is that causes it is going to probably be a lot harder to tease apart. I don't think it's going to be as straightforward as cortisol levels being higher on average. It's going to be a lot of things. But it's important work that's being done. We had a conference at EVMS not that long ago. Abby participated, and Dr. Parson, Henri Parson, who's my colleague here at EVMS, we presented a little bit about diabetes and the healthcare disparities and equity. And there were people from the NIH who were there. They were very interested in studying the effects of racism on chronic health. It's fascinating, and it's needed research.
Wow, thank you so much. That is very, very interesting in terms of people researching the correlation between racism and how that may affect their health physiologically. You've got some great information here, and I want to give you an opportunity, just as we approach our end time, I want to give you an opportunity to go ahead and press through. And once we're done, give us one takeaway, and then we'll bring this thing to a safe landing.
That sounds good. Just to summarize the drugs. So the other class of medicines that I didn't mention are called the SGLT2 inhibitors. Those are drugs like Jardiance and Farxiga and Invokana. They're pills rather than injections. They're once a day. And they're also associated with some weight loss and with blood sugar lowering. The thing that's really special about these lower two classes of drugs, the GLPs and the SGLT2s, is that these drugs have been studied in people with heart disease and have been shown to reduce their risk for further heart problems. They've been studied in people with heart failure, and they've been shown to reduce their risk for being hospitalized for another episode of heart failure or dying from heart failure. They've been studied in people with chronic kidney disease and have shown that if you take one of these medicines, you're less likely to develop end-stage kidney disease. And when I was in training, we didn't have drugs that did these things. All they did was lower the blood sugar. So it's a really exciting time in diabetes research and mostly in diabetes clinical care, because we have drugs that do more than just lower blood sugar. Insulin gets a bad rap. I mentioned already that just because you start insulin doesn't mean you're going to be on it forever, but it might be the right thing for you. I am very happy about insulin because without insulin, I wouldn't be here because of my type 1 diabetes. Sometimes people need one injection of insulin a day. It's called basal insulin. It's a long-acting insulin. Sometimes people need that and some insulin with their meals. It kind of depends on how long you've had diabetes and what your blood sugars look like during the day. And there are probably some people who are listening that have utilized insulin pumps. I wear an insulin pump that you fill with insulin every few days, and it provides insulin on a regular basis. And I'm happy to talk about that later. So the last little bit is just a word about monitoring. So when I was diagnosed, 1989, it was June 22nd, 1989. I remember that day because I was 12 years old, and my friends and I were all excited because the first Tim Burton Batman movie was coming out that Friday. And I was going to go to my friend Sasha's house to sleep over, and some guy in Richmond had won the Batmobile from the movie. So we were going to go see the Batmobile and then watch the movie, and then probably, eat garbage all night at this kid's birthday party. And I was in the hospital because I've been diagnosed with diabetes. So boo-hoo. I ended up seeing the movie with my parents, but it probably wasn't as much fun. So back then, to test my blood sugar took me 2 minutes at least. It involved a huge drop of blood and a diabetes monitor that was like a brick. People before that, maybe 10 years before that, didn't have blood glucose testing equipment at all. They were testing their glucose in their urine. So I still take care of plenty of people that remember those days. As I got older, the blood sugar testing equipment got much better so that it was 5 seconds with a tiny amount of blood, the stuff that we use now. But now everybody's using continuous glucose monitors. This is the sensor that I wear. It's called the Dexcom. This is the other sensor that's very popular called the Libre. They're very tiny. They don't measure blood glucose. They measure the fluid in between cells, how much glucose is there. They're painless, they're temporary. You put them on for 10 or 14 days and then take them off, and it will read out your glucose value to your phone or your insulin pump. And there's some really exciting advances in pump therapy where the sensors and the pumps talk to each other. These are becoming more affordable, but just as important as insulin costs. I feel like that's one of the only areas where Democrats and Republicans are on the same page is when they talk about insulin costs. I feel like there's been somebody with type 1 diabetes at every state of the union for the last number of years. We need to get these things affordable for people too, because everybody with diabetes, especially somebody who's on insulin or a drug that could cause a low blood sugar, should not have to stick their finger anymore. They should have access to these devices. So that's actually it. This is a picture of some of us at our diabetes screenings in Western Tidewater. We have a really great project looking at diabetes in the Western Tidewater community. Abby, I wanted to mention a good resource for people to go to. There's really not much better than the American Diabetes Association. And if you go to diabetes.org, you'll find all kinds of information about the testing, about the medications, everything that you can think of. But please, 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 don't hesitate to email me. I'd love to make connections and answer any questions that I can, in any way. So that's my last slide. Sorry for talking so much and maybe going fast and going over, but I like this stuff.
No, man, I appreciate it. From one type 1 diabetic to another type 1 diabetic. We appreciate it because it keeps us alive, right? So yes. I do just want to say on behalf of Phi Beta Sigma, Beta Sigma chapter, that we do appreciate you, Dr. Lieb, and Ms. McMillan and Dr. Parsons. We appreciate everything that your team has brought to us over the past couple of weeks. And we look forward to hosting you all again on next Thursday for the workshop when we start talking about diet and lifestyle. That way we can understand the totality of diabetes and how it affects us as a people, how it affects us as family, how it affects us ultimately as a culture. So I want to say again, thank you everyone, to our audience. Thank you for sticking with us. Please share this information with your friends, your family. Share it with the people that are sitting next to you and the people that you have to call, okay? Because we need to get this information out there. Thank you again for our Sigma Virtual Hour. This concludes everything. Have a good evening, each and every one of you.